So thank you, the Renal Research Institute. We have the pleasure today of presenting a section called Children and Adolescents with CKD, ESRD, Illustrative Cases. And it is my pleasure to welcome our group of faculty presenters. My name is John Mann. I'm a professor of pediatrics at Nationwide Children's, The Ohio State University. And no, I am not from the South Rim of the Grand Canyon today. I might wish I were. My fellow presenters are Dr. Melvin Bonilla-Felix, who's a professor of pediatrics and chairman of the Department of Pediatrics at the University of Puerto Rico, and also Guido Feeler, who is a professor of pediatrics and also department chairman at Western Ontario University. So we are going to start with Dr. Bonilla-Felix's presentation, and this is really meant to be interactive, so you will see us all participating in the discussions of these presentations. So with that, Melvin, I'm going to turn it over to you.
Okay, well, thank you. First of all, I'm really honored to be part of this presentation. And what I would like to do for the next few minutes is to discuss with you an interesting case of a boy with low urinary tract obstruction. And we're going to discuss the medical management of the patient, but also would like to focus on the ethical dilemmas of the fetal and the postnatal life that usually confront in these patients. So our patient is AGC, and he was referred to our service when the mother had 24 weeks of post-menstrual age, because in the prenatal ultrasound, it was found that he had severe bilateral hydronephrosis and severe oligohydramnios. So the parents came to our office, and basically the first question was, well, we have heard that in these cases, there are some type of prenatal surgeries that can be done. And I would like to get from Guido or John, any one of you, will you offer prenatal intervention to this fetus, to this family that have a baby with severe prenatal renal abnormalities and severe oligohydramnios? What are your thoughts?
Well, it's Guido here. I would be reluctant to do that. I know that there have been some great series that have been published, but there's a very high complication rate, and even the intervention may result in the demise of the fetus. I mean, you have to really explore the culture of that family and how they would feel about this. But it is my understanding that even despite of some 30 years of extensive research into this, that these procedures are associated with a very high risk, and that you may get some amelioration of the low nephron endowment, but they still may have significant pulmonary hyperplasia.
Yeah, I agree, Melvin. To me, this is extraordinary care. And it's not that we don't offer extraordinary care, but we make sure that everyone goes in with their eyes wide open, so to speak, and very much the culture and wishes and interests of the family are a big part of this kind of decision.
Yeah, and I think that was exactly what we thought too. And actually, if you look at the data, as Guido was saying, although people have been doing prenatal interventions for several years, it's still very controversial procedures. And actually, for some of these procedures, we have seen a decline over the last decade of these procedures. So the first intervention that you can do in someone like this one is if the baby has any evidence of severe hydronephrosis, but the kidney looks normal, you don't see dysplasia, and they have normal amniotic fluid, the only intervention that you need is to repeat the ultrasounds. So usually the OB, what they will do is do Wilkin ultrasound and monitor that patient closely. However, in cases when you see oligohydramnios, but the kidneys look good, they have hydronephrosis, but there's no evidence of dysplasia, sometimes the perinatologists offer either cystoscopy or vesicoamniotic shunt. And we're going to talk about each one of these more specifically. When you see severe oligohydramnios, and then you start seeing dysplasia, renal cysts, and evidence that there's a lot of damage to the kidneys, then the vesicoamniotic shunt should be offered. If you're going to offer that, probably consider also serial amnioinfusions to try to preserve the pulmonary function and try to prevent more pulmonary hypoplasia. And finally, in babies, in fetuses that you don't see, there's no urine output at all, and then you feel that there's no kidney, the kidney function is so bad that there's nothing that you can do for the kidneys, but you're concerned about pulmonary hypoplasia. Some people are doing serial amnioinfusions. So, but before you decide about that, some things that you want to know is that you have a karyotype, and you want to make sure that, number one, this baby have normal chromosomes, because if you have a chromosomal abnormality, and then if you look to the prenatal ultrasound, and it's not only the kidney, he may have congenital heart disease, and you have severe brain CNS abnormalities, then the prognosis of those babies is so poor, and prenatal intervention is not really considered. The other thing is you are going to do this in babies who have oligohydramnios. Because if your amniotic fluid is normal, even if you have severe renal abnormalities by ultrasound, it's not really justified to do an intervention. And finally, one of the other parameters that OBs usually use is the prenatal fetal urine. And what they do with the fetal urine is they go directly to the suprapubic top of the fetuses, and they get serial urine samples. And what you see here is what has been considered a favorable prognosis. Sodium less than 100, chloride less than 90, osmolality less than 200, beta-2 microglobulin less than 6. The problem with this is, again, this is not specific. And there's some fetuses that may have this urine profile, but when you look at them, the prognosis is not that good. So again, prenatally, it's very difficult using these parameters to decide who is going to have good prognosis. The first procedure that we took was fetal cystoscopy. And actually what you do, literally, you go to the baby's bladder with an endoscope. And from the bladder, you go to the urethra. You try to localize the bladders. And once you see the valve, the posterior urethral valve, then you do the valve ablation with laser there in utero, in the fetus. As you can imagine, this is associated with a lot of morbidity, but also mortality. And the few cases, the case series that has been reported show that you might see a better survival in terms of kidney function. But again, when you look at this, there are very few centers doing this, and the evidence is very limited. The procedure that probably has been done more widely is the basic amniotic shunt. And when you do, you go to the baby's bladder and you put a catheter there, and the other end of the catheter is in the amniotic space. The idea of this is you bypass the bladder obstruction, then you have the urine flowing from the bladder directly to the amniotic space. And in that case, hopefully, you're going to relieve the pressure from the kidney, and you're going to have less renal damage, and also you're going to start producing more amniotic fluid, and hopefully this is going to be also good for the lung hypoplasia. However, the only controlled trial that has been done using this has been called Pluto, only 52 patients. And when you see the conclusion here was, there is no clear evidence if fetal basic amniotic shunting is beneficial in the long run. So again, this is the one that has been used more widely, but it's still very controversial, and there's no evidence of a definitive benefit doing this. And finally, these are patients that have no renal function at all, completely anuric. And when you're doing serial amnioinfusion, literally infusing normal saline into the uterus is trying to make sure that you create amniotic fluid. Hopefully, this is going to reduce the severity of lung hypoplasia. Again, these are fetuses that are going to have very high mortality. Very few cases has been done. And again, it's very controversial whether this helps or not. So the challenges for these prenatal interventions, the first one is that by the time that you see the oligohydramnios and you decide about doing something, it's usually sometime between 20 to 24 weeks, like our case. By that time, a lot of the renal development has occurred already, and you probably have already established dysplasia. So how much are you going to help the kidneys? It's not clear by this point. And also, it's very difficult to make and establish a precise diagnosis prenatally. Because even if you look at the ultrasound here, that you see the famous keyhole sign for babies prenatally, the babies that have the prenatal ultrasound with the keyhole has been considered specific for posterior valve, but actually it's not specific. It has been shown that you can see the same thing in babies with other anomalies. So it's difficult to determine which is the one that really needs the procedure before birth. in our patient's AGC, the OB who evaluated the patient decided he was not a candidate for prenatal intervention. So the recommendation was to basically stop the pregnancy and terminate the pregnancy, and they offered termination of pregnancy to the parents. However, the mother is a nurse, so she refused the termination of pregnancy. The father, interestingly, had posterior valve when he was born, so he thought that it was not a major problem to have posterior valve because he had babies, he had 2 kids, and he had a normal life. So they refused termination of pregnancy. So he was born at 33 weeks of gestation. In the delivery room, immediately he required intubation, resuscitation, was transferred to the ICU. He was a big baby. However, when he came to the NICU, he had the lost ear, small thorax, flat nose, contraction of the lower limbs. And as you can see, what I'm describing here is the classical Potter sequence. And when you see the classical Potter sequence with a severe hypoplasia, the mortality is still very high, higher than 90, close to 100%. So once the patient was in the ICU, it was placed in mechanical ventilation. They had to put him in the high-frequency oscillatory ventilation. He developed multiple pneumothoraces requiring multiple chest tubes. A Foley was placed, but over the next 3 days, he wasn't making much urine. And as you see here, the creatinine immediately started rising up to 2.1 in 72 hours. He developed multiple electrolyte imbalances requiring inotropic agents. So the NICU staff say, well, come here, talk with the parents, and the mother immediately asks, can we dialyze the baby? So Dr. Mann, Dr. Filler, any one of you, will you offer dialysis to this infant at this point?
So again, Melvin, I think having had these conversations ahead of time, this should not be a big surprise and a new question. So ideally, we have all this worked out ahead of time, and we laid out these scenarios. If your child has severe lung disease and is requiring maximal pulmonary support, are we going to go ahead and do dialysis? So we would have worked these things out ahead of time in the ideal. And I think we have had children like this that we have dialyzed, even though we felt that things were grim, but we felt that given the parental issues and concerns, that giving a trial of dialysis would be important. One other caveat I would make is that dialysis is extraordinary therapy, and dialysis can be discontinued. So we always say to the parents, if we're going to do dialysis, we recognize that at some point it may be in your baby's and your family's best interest that we discontinue dialysis. So we do not ascribe to the position that once you put them on dialysis, you can't take them off. Guido?
Yeah, I would like to agree 100%. In our institution, we would also really draw a cystatin C because in the first 72 hours, probably in the first week, the creatinine is largely influenced by the mother. And I see the initial creatinine was 0.7. And it's very difficult to assess really what the GFR of this baby may be when it's 18 months old. As you know, you only use about 10% of the nephrons on day one, and then you start recruiting them. Before birth, only 3% of the blood flow goes to the kidneys, and by the age of 18 months and then thereafter, it's 25%, and that process is slow. So from the slope of the rising of the creatinine, it's difficult to really assess what the nephron endowment is. The peak helps. If the peak is 1,000 micromoles per liter or 10, then you know there is no function at all. But the peak doesn't come until a number of days, right? And so that's very difficult to assess. We're very fortunate we can get a cystatin C in 45 minutes with an eGFR calculated, and we've just published also like a normative nomogram for that by post-conceptual age. And if I would know that this cystatin C is 7, then I would probably say that there will not be much urine output, and the child may die from the non-renal complications. And I would have another discussion with the parents. If the creatinine is only like the cystatin C is only like 2.5 or so, there is some hope that within a matter of a few days, with that normal adaptive process, there may actually be urine output. And it might be, if they're absolutely wanting that, then that we would offer maybe some short-term CRT. I wouldn't necessarily put a PD catheter in because there's maybe, depending on what the residual function is, it may be that in a week the baby can come off dialysis and then you have another surgery for that.
Okay, so well, thanks for your comments. And actually the concern here, as you said, is in 72 hours it wasn't making urine, the creatinine was increasing. So the question about to dialyze or not to dialyze, this scenario, deciding about neonatal dialysis is not uncommon. It's probably one of the most important ethical questions that we have to confront as pediatric nephrologists. So one side you have the issue about, is dialysis going to extend the patient's life? And the other side is, what about the impact on patients' quality of life? And this second one is more difficult to quantify because quality of life is really very subjective. The quality of life, I bet that for Guido and John and myself is probably going to be very different from other people, from our parents, from the people that are working in the NICU. So this is something that can be very subjective and it's very difficult to quantify. And then you might think, well, probably it's not good to dialyze this patient because it's going to be, it's a burden for the baby to be on dialysis. This is painful. It's a burden for the family. But on the other side, if you don't dialyze and the baby died right away, it's a burden for the family losing a baby. So what is going to be worse from the family is definitely a decision that you have to take, talk with the family, discuss with them. And the other major issue in here is the other systems that are involved. And Guido was saying, probably at this point, we don't know whether the baby is going to be able to recover kidney function. But what we know is we have a baby with severe pulmonary hypoplasia, and that's probably the major limiting factor here right now. As Dr. Mann was saying, once you decide to start dialyzing, some people are concerned about, if I start, can I stop later? And this is a more difficult question to answer for many clinicians, but the answer is sometimes you don't even need to decide because just doing the dialysis to that baby that is very sick, the patient decides for everyone, and sometimes they just don't tolerate, and even the parents, sometimes they decide this is it. Because when they see that the baby is not improving, then the decision is easier for them. What is important is that if your decision and the family decision is for go dialysis, you have to make sure, you have to be clear that this is not the end of your role here as a nephrologist. This is a time to make sure that you have a clear, specific palliative care plan for that family, because this is the family needs you most right now. Because you are not offering dialysis, this is not the end for the nephrologist role here. So, as we were saying before, the major issue of the baby here is probably not really the renal function. We could dialyze babies. And actually, when you look at the outcomes of babies, infants with renal failure and only renal failure, it's pretty good right now. So, but here, when you look at the survival rate of those patients with severe hydronephrosis, the most important factor is whether they have oligohydramnios or not. If you have a baby with severe obstruction but no oligohydramnios, as you see here, the prognosis is pretty good. If you have severe oligohydramnios, then you see most of those babies will die within the first few days, the first month. But then you see if the baby is alive by the end of a year or 2 years, then the survival curve is very stable after that. And then why do these babies die? Well, pulmonary hypoplasia. This is the cause of this. If you have pulmonary hypoplasia, then the mortality rate is much higher. And again, the death for mortality, for the mortality for pulmonary hypoplasia usually is something that happens very early in the course, in the first few days or very few weeks. After that, if by 1 year or 2 years the baby is alive, then the survival curve is very stable, and those babies probably going to stay alive because we can dialyze and transplant. So AGC, the clinical course, after he was born, we did the ultrasound, he showed bilateral severe hydronephrosis. The case was discussed with the parents. We decided not to offer dialysis because he was so unstable that we were sure that he was not able to tolerate any type of dialysis. And they agreed with that, but they refused DNR. So he was there for 3 months, had a couple of cardiorespiratory arrests. And after 3 months, he was stable enough to go on a conventional ventilation with tracheostomy. We were able to do the cystogram that shows severe grade 5 reflux on the left kidney, posterior ureteral valve. The urologist took him to the OR. They did valve ablation, circumcision. And as you see here, Guido was talking about the peak. The highest peak of this baby was 4.2. And then after that, before the surgery, with the Foley, he started improving. And you see some peaks because he had a couple of AKI episodes secondary to medication or the cardiorespiratory arrest. But then later, after a few months, the creatinine started coming down to 0.6 and more stable. So he was sent home with tracheostomy, gastrostomy tube, with an EG showing severe brain damage. But a week after that, he came back to the hospital. Seizures, prolonged hospitalization, creatinine was 0.6, but then it started going up to 0.8, 0.9. We decided to repeat the ultrasound that showed this thick trabeculated bladder. We called the urologist and they said, well, probably the bladder is a problem right now. Let's do oxybutynin. Let's do intermittent cath. But the baby had by that time like 2 UTIs and keep having UTIs. Fungal UTIs that require prolonged antifungal therapy in the hospital. And now he's 10 months old. He's still in the hospital. He's still admitted with seizure on the mechanical ventilation by tracheostomy, recovering UTIs, right now getting antifungal medications. And the question is, what do we do now? One alternative we could say is, well, let's do the BCUG again. And if we have reflux on the left, but the radionuclide scan show that he have good function, let's do anti-reflux surgery. But if the nuclear scan show that he have reflux and no function at all, let's remove the left kidney that have the bad reflux and probably the more dysplastic one, and we might be able to stop the UTIs. Or why don't do urodynamics? Because if baby have a posterior valve, and if we're going to think about transplant in the future, or in a baby like this, should we just do vesicostomy? Just to improve the quality of life and make things simpler for the family. So, Guido, John, what would you do at this point? And I'm asking the question because we're at this point right now. So, what are your thoughts here?
So I make sure I work with a really good pediatric urologist. And I would just, what I see so far, Melvin, is drainage is what this child needs. And right now, urinary tract infections are most likely related to improper or ineffective drainage. So I tend to vote for the simplest and go for a vesicostomy and see if by having good drainage of the urine, we can minimize the urinary tract infections and allow the natural history to play out.
Okay. Any different thoughts?
I agree. Perhaps in our center, we have a wonderful relationship with our peds urologists. They're our best friends, and we might actually have done the vesicostomy right away after birth, sort of bedside, because that gives you the best drainage, and you can actually leave that until they're age 6 or so. That's when they start becoming self-aware, and then you have a lot better idea where everything is, and you could actually do a metrophenol, because I think a continent diversion, when the valve is so extended, you can never really repair the bladder, right? You need a neobladder. And for that, an older age is okay. I would have opted for a vesicostomy at this point in time with the option of doing a metrophenol at a later time. I wanted to come back to the previous question. When I looked at the ultrasound, I was impressed about the fairly substantially good renal cortex volume. And this may just be another tool to assess where the long-term prognosis might be.
Which is true. He had cysts, but he had good renal mass there, okay? So we basically went through the discussion with the urologist, the whole team, and the decision was to go for vesicostomy, who is going to get hopefully soon to see if at least we can send the baby home. So I just want to finish this, again, going back to the ethical dilemmas that we usually confront in these babies. For me, this has been a difficult case because I thought that we probably were, the neonatologists were too aggressive with the baby initially, even offering the high frequency ventilation. But I think that we have to remember, for us as providers, we must continue to follow an individualized approach in decision-making for each child, and to recognize that regardless of the decision reached about dialysis or not, again, there is a continued duty to care for patients and family to maximize remaining quality of their life. So if you decide we're not going to dialyze this baby, this is not the end of your work here. You need to keep seeing this family, making sure that at least you provide support to this family, because they're going through one of the toughest times in their life. So thank you. This is not a baby, but this is another infant that we had with similar condition, not pulmonary hypoplasia. We dialyzed this one for almost 2 years, even when she had severe brain damage. But as you see here, she was interactive. Going to bedside was really, you go there and it was delightful to see her. As soon as you approach her, she will put her feet in your mouth and start playing with you. And we did it for 2 years. And after 2 years, one day in the morning the mom went to the bed and she was there. But I think those 2 years, she had quality of life, and the mom basically probably took her long before she could realize how sick the baby was. So thank you.
The ethics of withholding or offering renal replacement therapy in older children are very clear. And you really have no grounds to deny that unless there's another life-limiting condition there. But the ethics in the neonatal period are different. And you really need a very careful and antenatal approach to this, so that you run through the scenarios and come to a conclusion beforehand. So for instance, if this baby was impossible to oxygenate and was anuric, then probably the best thing is to actually extubate and let it die in the arms of the mother, and make sure that you have all the memories and so on, systems in place. But I think one of the hardest things in the neonate is to assess what is the potential for the kidney function. And we really need a complex way. I know, especially the group in Miami, they really propose to use renal volume Z-scores. And that is a good idea, except that I have never found a solution to the hydronephrosis, because you have to subtract that, of course, right? And can you just two ellipsoids that you subtract from each other? I don't know, because I've never seen that. I think cystatin C and beta trace protein are better markers to get an idea about what is really the neonatal function, because they don't cross the placenta. And I realize that the availability is very limited, but maybe that would have been actually a reason to send it out and get a cystatin C, because the peak, as you clearly showed, takes a while, and only then can you assess. And it was only 4, it wasn't 10, right? So the probability, I would be curious, what is the kidney function of that child now?
He has a creatinine like 0.7 right now. So he had like more than 5 episodes of AKI on top of this, but it usually comes back to 0.6, 0.7, which is really, I'm really surprised. I'm really surprised with that, because we have babies that probably were not that sick, not that much insult, and with the creatinines that are much higher than that. So
it goes back to Guido's earlier.
Right now.
It goes back to Guido's earlier point that there seemed to be a reasonable amount of parenchyma in those kidneys, right? Yeah. And so I think that was something to feel optimistic about.
I think that, and the good thing with the ethical issue with this baby, he has so many problems. And at a point, very soon, dialysis was not an issue anymore. So the problem was not whether we needed dialysis or not, because his creatinine came down to 0.7, 0.6, it was making urine, electrolytes were fine. So the issue was not really dialysis, was all the other complication that he had.
Yeah, the issue is also whether or not there's urine output, right? I think if there's anuria, all the babies will die without renal replacement therapy. But if they start picking up after the physiologic 24 hours oliguria, and they have urine output, and I presume that your child actually has high output renal failure, and the concentrating defect and probably some salt wasting, they actually do well then. And it's so hard. I think the lesson from your beautiful case is that oligohydramnios alone cannot be a decision-making point for the prognosis, and that we need to continue to strive towards better ways, like a biomarker that assesses only neonatal renal function, like the measurement of the renal parenchyma, perhaps with some CT or MR volumetry, you might be able to do that, actually, and then have some reference intervals, and then base it on that. That will really allow for much better guidance of the parents.
It's interesting. There is a good article on families that were recommended termination of pregnancy based on the severe renal abnormalities, and 10 of those families that refused termination of pregnancy, they were followed. 5 of those kids died within days after birth. They have severe oligohydramnios. The other 5, 3 of them had oligohydramnios and 2 of them didn't have oligohydramnios, but the abnormalities were so severe that the OB anyway recommended termination of pregnancies. The one that didn't have oligohydramnios did great with completely normal renal function, no praying at all. The other kids with oligohydramnios, those patients did well, and they eventually require support, and they have CKD. But all those 5 kids still alive. 2 of them, requiring some form of support for the chronic kidney disease. But the ones that didn't have oligohydramnios, they had complete normal function, and they were recommended termination of pregnancy before. So as you say, oligohydramnios by itself, if it is severe anuria, then yes. But some of those kids with oligohydramnios, we just transplanted one like 6 months ago, and he's 5 right now, and he's doing great. Okay, so thank you.
Good. All right, Guido, we're going to turn it over to you next.
Okay, so I would like to share with you an interesting case with congenital nephrotic syndrome. So this is the first child of related parents. They're first-degree cousins from the Middle East. The father is a nephrologist, the mother is an HLA technician. Both are very healthy. Family history is really non-contributory. The baby had antenatal ultrasounds, which demonstrated increased echogenicity of the kidneys and a very large placenta and failure to thrive. There was a spontaneous vaginal delivery at term with obvious failure to thrive and small for date. The birth weight was 2.17 kilos and the length was 46.5 centimeters with a Z-score of -1.65. And the child developed within hours a severe nephrotic syndrome. And when blood work was done, albumin was undetectable and there was large proteinuria. So my question number 1 is, do you think this is the provisional diagnosis of congenital nephrotic syndrome? Because of the very large placenta, you might consider Finnish type, even though this family is of Arab descent. And you want to start some conservative therapy with fluid restriction, with diuretics, with albumin, but it's not responsive to aldosterone, Lasix, and albumin. And what would you do? Would you do a bilateral nephrectomy and PD? Would you continue albumin infusions and diuretics and try to get the patient into a compensated nephrotic state? Would you consider a kidney biopsy to get some answers what might be going on quickly? And would you get genetics?
So Guido, could I pick 2 choices? So we would clearly get genetics, although we understand there may be some parts of the world where getting genetic test is not a simple matter. But in this population, genetics now trumps a biopsy. The information you're going to get from genetics will help you look prognostically at this patient. The kidney biopsy findings can be very non-specific in this age. I would also like to choose continued albumin infusions and diuretics. And we certainly have had children where we've done IV albumin 5 days a week to be able to come up with some reasonable amount of fluid balance and allow some opportunity for nutrition. And only after going through aggressive albumin and then alternate methods of giving diuretics would we then move to consider interventions like bilateral nephrectomy and PD.
Very good. Thank you. I think we have to, first of all, review very briefly that you can have primary causes such as the Finnish type congenital nephrotic syndrome, but you can also have diffuse mesangial sclerosis or FSGS. And on some biopsies, you actually may find minimal change. And then you can have some syndromic congenital nephrotic syndrome, but you also need to rule out all the secondary causes such as congenital syphilis, other perinatal infections, mercury intoxications, etc. Of course, all this was done and there was no secondary cause identified. When you do a kidney biopsy, you can do some fancy things and you can actually look for podocin and pronephrine expression. And if there's no expression, then that would be quite specific to Finnish type because there wouldn't even be a residual. But it was elected not to do a kidney biopsy, and it's difficult in a newborn, and you might have to ask the surgeon to do a wedge, and there is likely going to be a lot of ascites, etc. So that's not an easy thing to do. This is a very simplified cartoon of all the proteins that make the network between the individual food processes of the podocytes. And nephrin would be the one here in purple. And it forms basically a zipper. And when that is absent, which you get with the congenital Finnish type, then you have such large proteinuria that you can't get this under control in a normal, with conservative treatment. So, the genetics were sent. Everyone thought it was Finnish type, but it actually turned out to be a homozygous mutation at C1040, which was just one change of an amino acid, but that didn't come for 3 months. The histology was not done until the child transitioned to my care, and it was actually FSGS because this particular mutation has never been reported with a biopsy. And so the choices were, of course, bilateral nephrectomy or conservative treatment. And Dad really wanted conservative treatment. And he actually fired the first hospital and he fired the second hospital, and returned to a different doctor at the first hospital. And the child was actually eventually managed on conservative management. I just want to quickly point to you here. So you have two major mutations, one at the very beginning of the whole gene that leads to a complete non-existence of that extracellular domain. And then Fin minor is a mutation here, relatively large, down the thing. This particular patient had one at 1040. So that would affect, but it's only one protein. It might just affect the stereoscopic construction of that long chain with these nodes. And that might actually have responded to therapy in this particular case. So what happened was that the family was offered and they decided against that. And so the child actually got 7 days a week albumin infusion, and that could be weaned slowly. And then he got into a compensated nephrotic stage and slowly progressed into chronic kidney disease. The child was transferred to my care when the GFR was 30, and he progressed very slowly on quite aggressive therapy to end-stage renal disease. These are the cystatin C eGFRs of this boy. So it's a fairly slow progression, but it went into end stage. And so at this point in time, the parents had always wanted a preemptive transplant. But at the time when we had to really start dialysis, the serum albumin level was still 15 grams per liter. And the child was nephrotic. From a laboratory perspective, the cholesterol was 12 millimole per liter, so very, very high. And there were actually some abnormality in his coagulation as well. He was hypercoagulable. So what would you do? Would you do a bilateral nephrectomy and hemodialysis catheter insertion until the baby is no longer nephrotic? Or would you do a transplant in the nephrotic stage? Or would you do, as the father absolutely insisted on, he wanted actually unilateral nephrectomy and the PD catheter insertion because he lived 2.5 hours away from our center and he felt that they could not relocate to our center for 3 months of hemodialysis or any other invasive things. He wanted to do PD at home. So what would you do?
Well, what I would not do for sure at this point would be transplant with a albumin of 1.5 and the nephrotic stage. But the issue of unilateral versus bilateral nephrectomy is still very controversial. My experience with unilateral nephrectomies is not very good. There is an old report several years ago that a lot of those kids may die within the next few days after the surgery from sepsis. And in my experience, some of those kids eventually need to go for the other kidney again because they keep, they're hyperfiltrating. And then they're making urine from the other one, and they still, they're so nephrotic that it's very difficult to just correct the nephrotic syndrome with that. But I want to add another alternative there that I didn't see. What about medical nephrectomy? This is something that we have tried with some of those patients. So you are using a combination of indomethacin with high-dose ACE inhibitors, and you may decrease the renal function to a point that the albumin goes up. It's much easier for them. And we have done with some of those patients that as we have been able to gain, some years. And actually, we have right now that eventually she developed end-stage, she's anuric, she's on PD, and never get a nephrectomy from the kidney. She's right now ready for transplantation and never had surgical nephrectomy. And what we did was try medical nephrectomy. So sometimes you can start decreasing the function. Doesn't work all the time, but some of those patients, it might work. And for a parent like this one, the father didn't want the surgery. So probably offering medical nephrectomy will be a choice with a peritoneal dialysis.
So the question here really is, what would give you the fastest way to transplant, right? And a bilateral nephrectomy would immediately stop the protein wasting, and hemodialysis would result in less removal of protein than PD, because we always have some loss of protein with PD. But the father was not very happy with this at all, and he sought other opinions, and he insisted on a trial of PD and unilateral nephrectomy. We actually tried the indomethacin. He was already on a max dose of 0.6 milligram per kilo of enalapril, and he was actually on 4 antihypertensives because he was extremely hypertensive. We said to him, there's no data that would suggest that a unilateral nephrectomy might work, and the albumin level could still remain so low, and we still would end up with the same thing. The other big piece is, of course, you can try a retroperitoneal unilateral nephrectomy, but you might nick the PD, the peritoneum, and then you may still have to switch to hemodialysis. So anyway, here is the serum albumin and the cystatin C since the start of the dialysis. And as you can see, dialysis and the indomethacin, which was 3 milligrams per kilo, did not do anything. It didn't get him out of his nephrotic state, even though the GFR dropped further. And this process was very long. And after 2 months, we decided this is not working. So actually, one of our peds urologists is an amazing surgeon. He actually managed to do the unilateral retroperitoneal nephrectomy on the left side. We chose the left side so that we would, if still needed, go the right side, perhaps with the transplant. And as you can see, it had quite a profound effect, and the albumin level rose. And actually, by the time he got transplanted, it was actually a normal albumin level. And the GFR, of course, dropped, but it dropped fairly slowly. What really happened also was that his urine output dithered away, and he eventually then went on to get the transplant, and there were no complications. Something else happened, which is very interesting. We are doing sodium MRIs. This is a healthy 6-year-old boy on the left, and these 3 coils, this is a section through the thigh, and these 3 coils here are coils with a reference sodium concentration. There's actually a 4th one which doesn't contain any sodium. And usually at that tender age, you have very little sodium deposits in your skin and in your muscle. But this boy had a massive amount of sodium in his tissue. And he had, before the PD was started, high output renal failure, and he was so used to drinking a lot that we had an ultrafiltration of about 1,300 to 1,400 milliliter every day, and a net sodium balance of minus 13 millimoles. And by the time he got into the transplant, he was off the 3 antihypertensives, and the all of which had been at the maximum dose, and he was actually only on a fraction of enalapril at the time of the transplant. So my next question is, what is the model of clinical practice here? So obviously there were 2 points where the physicians had a recommended best available evidence approach to treatment. They wanted to treat it like a finish type, and they wanted to do a bilateral nephrectomy and hemodialysis, but it wasn't done.
So obviously, Guido, you all were very collaborative in your decision-making, and obviously the family had a lot of input and had their input obviously valued by your team. I think that is an effective model when you have a family that is thoughtful and has strong opinions and reasons for what they think is best. You know, I hasten to say I would never do something that I thought was dangerous or ill-advised for a child, even if the family wanted it. But I think in a collaborative model, you take into account the parental wishes and you come up with a decision that you think best represents the understanding of the parents and the healthcare team. So obviously, this was a family that had some really good insights.
Thank you. So really, this is an example, in my opinion, for shared decision-making, which is an approach where clinicians and parents share the best available evidence when faced with the task of making decisions, and where the patients are supported to consider options and achieve informed preferences, even though they may go against what you consider the best practice. And the guiding ethical principle is really based on individual self-determination, or in this case, the self-determination of the caregivers. And it is a desirable goal, and clinicians need to support patients to achieve this goal. It does not mean that we abandon them. And it is really focused on the intrinsic tendencies to protect and preserve our well-being. And informed consent beyond that of simple information transfer towards honoring informed preferences and balancing good clinical practice with benefits and justice is important. So there's actually very good literature about that. A study of 86 randomized controlled trials showed that knowledge gained by patients, more confidence with decision, more active patient involvement, informed patients elect to do more conservative treatment options, as was the case in our case. And the decision aids for people facing health treatments or screening decisions are available. And I think we actually need to migrate a lot more into this, especially when we have very, very well trained, highly intelligent parents who have their own set of values. So one thing that I want to share with you very briefly is what is called choice talk. And you start by stepping back and saying, now that we've identified the problem, is it time to think what to do next? Offer the choice, offer the evidence, starting with good clinical practice, and justify the choice and check the reaction. Like, shall we go on? Shall I tell you about the other options? Or maybe at this point in time, like was the case with this boy's father, they might burst right into it and say, well, what about this? I would prefer, etc. And then defer closure. I'm happy to share my views and help you make a good decision. And check the knowledge, list all the options, describe the options, really also highlight the harms and benefits, right? Especially with the unilateral nephrectomy approach on PD, there was a very high risk that the peritoneum would be nicked. And actually it did happen, but fortunately we could continue with the PD. And you need to provide patient decision support and summarize and focus on the preferences. And then have a backup plan ready. So we said, okay, we'll try this. We'll try the unilateral nephrectomy. But if we nick the peritoneum, we cannot continue with PD. We still have to provide safety. And then we switched to hemodialysis, right? And they were okay with that. And then moving to a decision, are you ready to decide or do you want more time? And then always offer a review, remind patients that decision can be reviewed, and that's a good way actually to arrive at closure. So I made a little cartoon. There's our family, and there would be the young doctor that you are, and we need to go away from a paternalistic approach where we just share information and recommendation to an informed medical decision making where the information goes both ways and you basically come to recommendations by constantly circling around the values and preferences. And with that, a few summary points. Not everything that looks like congenital finish type is finish type nephrotic syndrome. Parents, especially very educated parents, need to be intimately involved with medical decision-making based on their values and beliefs and circumstances. Dad was actually right. And in retrospect, we would have to concede that he gave his child 6 more years without renal replacement therapy. And he knew very well that you need like 3 kidney transplants, and he wanted the best longevity for his child. And of course, his remote location was a very major confounder for the decision. And lastly, I hope you forgive me, but I would like to share a book with you that you might find very useful. It's focused on behaviors that make you a successful scholar.
Yes, very good. And it helps to have a really thoughtful and informed family as part of the team. Thank you. So we're going to go ahead and move to our final case, which is a metabolic bone disorders in childhood CKD, a case presentation. So metabolic bone disorders are important considerations in our patients with CKD. In particular, bone health is an important determinant of quality of life, and it really correlates with other outcomes in these children. And we know that metabolic bone disorders can be primary or secondary. And as we'll talk about, CKD, metabolic bone disease, is really a secondary metabolic bone disorder. The kinds of problems children with metabolic bone disease suffer from include bone pain, increased fracture rate, bone deformities at times, and then certainly impairment of statural growth. So again, we see metabolic bone disease in many types of renal disorders, but I think we also need to remember to stay broad in our thinking about bone disorders in children with renal disease and not to assume that it's strictly the renal cause of bone disease. So this is a young girl, now a teenager with CKD secondary to a mitochondrial disorder. On muscle biopsy, this was diagnosed as a complex 4 deficiency with an RNDI mutation. And clinically, she presented to us in nephrology clinic with polyuria and soon developed hypertension and progressive CKD. She had a sensory neural hearing defect. She had short stature, which was treated with growth hormone therapy for some period of time. She had developmental delay. And she had a fracture at 9 years of age, a left humerus fracture, and ultimately required a kidney transplant and received a deceased donor transplant at 11 years of age after a few months of hemodialysis. At 15 years of age, she was 4 months status post her kidney transplant and suffered a left clavicular fracture. When we saw her in clinic, she was healing well, no evidence of radiographic rickets. She continued to have a chronically elevated serum lactate, which had been present really from diagnosis. And her mobility was impaired, as it had been for many years. She was able to walk in the house and walk for limited distances, but required a wheelchair for any kind of outside movement. She continued to have some fatigue and cyanotic episodes with exertion, but not significant enough hypoxia that she requires supplemental oxygen. And she had no activity suggestive of seizures. Medications included tacrolimus and MMF. She also required amlodipine, cholecalciferol, lansoprazole, and coenzyme Q. On physical exam, she was small for age, with a weight of 37.1 kilograms for a z-score of minus 3.46 and a height of 134.8 centimeters for a z-score of minus 4.22. She was thin, had generalized muscle weakness and hypotonia, and she had no bone tenderness or deformities. Here is her baseline or laboratory studies at the time of that clinic visit. As you can see, she had normal CBC. She had a serum potassium of 3.8, but a bicarb of 26. Her serum creatinine was 0.92 with a BUN of 12. Her glucose was 80. Her liver enzymes were unremarkable. Her calcium was 9.0, phosphorus 3.0, magnesium 1.8. Her 25 hydroxy vitamin D level was 57, and her NPTH was 54 picograms per mil. So the question I would ask you is, with this serum creatinine of 0.92, what is her level of renal function?
Maybe I can answer that. I mean, if you just plug in the Schwartz formula, you'll probably come up with something around 60. I can't do that in my head. But you are describing a patient with profound muscle weakness, and creatinine is to be converted from creatine based on your muscle mass. I would love to have a cystatin C, but probably more like number C.
And you are correct. And it really does bring up the point, as you said, Guido, this is a girl with terrible muscle health, muscle mass, and she is not going to have normal creatinine production. So to rely on a serum creatinine is really to misread her level of renal function. And actually, she had a serum creatinine of 0.92. And again, as you said, with a bedside Schwartz, she would come up with 61 mils per minute per 1.73 meters squared. Her cystatin C, however, was 2.20. And we have come to recognize that in large adult studies where patients have had combination of cystatin C and serum creatinines, that actually utilizing cystatin C, we come up with a slightly greater percentage of adults with GFR, for example, less than 60 than if you rely on serum creatinine alone. And actually cystatin C really correlates better with iothalamate clearance as well. So it is a better marker overall for patients. And certainly we can make a case that in this girl, it's going to be a more effective marker. Remember, we have a creatinine cystatin C formulation that CKID is actually published and actually represents iothalamate better than creatinine alone. But I think you can make a case in a child with severe muscle disease like this, a cystatin C alone is a better option. Because remember, the creatinine cystatin C combo was really developed in children with normal muscle mass. CKD, but normal muscle mass. And actually, if we utilize the cystatin C-based formula for this girl, we come up with 34 mils per minute per 1.73. Very different level of CKD, right, than thinking that her estimated GFR from the Schwartz formula is accurate. So just briefly, and I'm speaking about cystatin C in front of one of the cystatin C mavens, Dr. Filler, but remember CKD is really, the CKID study really has given us iothalamate standardized calculations, and utilizing the height, the cystatin C, the BUN, we can come up, and the serum creatinine, we can come up with a formula that better predicts what the iothalamate will find than if we rely on creatinine alone. Advantages of a cystatin C in terms of measurement of GFR is it's not affected by muscle mass or wasting. Cystatin C is really a product of the nucleus of cells, so every nucleated cell will contribute to the cystatin C. And interestingly, it's more accurate in obesity, because adipocytes have no cystatin C, interesting. So the extra cell mass of the fat cells, which does not generate cystatin C, then is sort of taken into account by relying on cystatin C. There are few disadvantages of cystatin C. It is increased with high-dose corticosteroids because it leads to muscle breakdown, so that you can see sort of a blip in the cystatin C because of that. And there are some inconsistent alterations of cystatin C with inflammation, not seen consistently. And the same with thyroid dysfunction. There are some malignancies where this could be a problem. And also some studies that have suggested that cigarette smoking may affect cystatin C, although that may be through the inflammation phenomena. So back to the fact that this girl's GFR is much more like 35 mils per minute than 60 mils per minute. Could this girl have a metabolic bone disorder? Could she have CKD, metabolic bone disease?
I guess she could have. You're talking about a GFR 34. So, usually you start seeing parathyroids are increasing as the GFRs are going below 60, 50. So 34, certainly she can have this. The question is if this is all that she has, okay?
Exactly, Melvin. Could she have a metabolic bone disorder? Almost undoubtedly, she has CKD, MBD, at least at a bone biopsy level. She has probably some abnormalities of her osteocytes and her osteoblasts and osteoclast. But could she have something that is more than just CKD, MBD? So, for example, could she have a metabolic bone disorder? Could she have a metabolic bone disorder that involves some inherited genetic bone disorder and elements of immobilization? Could she have immobilization plus CKD, renal tubular disorder, and some medication issues that affect her bone? Could she have an inherited genetic bone disorder, immobilization, and CKD, renal tubular disease? Or could she have a combination of all four of these disorders?
And you also mentioned that she also have chronic lactic acidosis.
Yes.
Chronic acidosis can also cause this. So I think she have a lot of potential causes that could be causing her bone disease. And definitely the rationale here will be, before we decide this is all related to the chronic kidney disease, in this particular case, as you mentioned, on immobilization, acidosis, the fact that she does have a mitochondrial disease and a metabolic disease that could be associated with a bone disorder by itself, I think it's extremely important to know the cause before we decide about how we're going to treat this, how we're going to approach this.
Yes. And one of the other interesting aspects of a patient like this is when you have a mitochondrial disorder, bone cells have mitochondria, by the way. So we could not expect that she has healthy bone cells from her underlying genetic disorder. So yes, so clearly it would be very reasonable to consider that she has a multifactorial metabolic bone disease, and it's not strictly CKD, MBD. And in fact, her CKD, MBD may be reasonably well controlled when you look at the fact that her PTH is normal. Her 25D is not quite at our goal, but close to in the desired range of 30 or greater. And then she also has normal levels of calcium and phosphorus. As you mentioned, Melvin, there are a number of things to consider. In particular, could she have a renal disorder like RTA or renal tubular acidosis that's part of this? She clearly has a mitochondrial myopathy, so she has some elements where she is not having normal mobilization and impact on her bones. As I mentioned, she could have some inherited bone issue related to bone cells being affected by her mitochondria. We could not find any reports of children with this type of mitochondrial disorder where bone disease had been looked for, so we don't know if it could be related to her mitochondrial disorder. And then also on this list, she does not have chronic corticosteroids or pulmonary disease or GI disease or rheumatologic disease. She had been evaluated for thyroid disorders and diabetes and does not have those kind of chronic endocrine disorders. but she is on chronic PPI, which has been shown in adult series to adversely affect bone mineralization. So there could be some element of that as well. So she certainly fits into the possibility of being a multifactorial metabolic bone disease. So what metabolic bone studies would help in her evaluation? So here is the list of studies that we typically get when we're looking at a child and looking for potential causes of metabolic bone disease. Wanting to exclude renal tubular acidosis, renal insufficiency, abnormalities of calcium phosphorus, looking at alk phos for either high or low levels that could indicate some underlying bone disease. Wanting to make sure that we're not missing hepatobiliary bone disease related to liver disease. Wanting to make sure that there's not celiac disease, which can lead to malabsorption and be a occult cause of metabolic bone disease. Of course, wanting to make sure that the patients have normal vitamin D status, do not have abnormalities of 125 production, wanting to make sure that there's not a parathyroid abnormality. And optional studies that we'll do looking at children for potential metabolic bone disease include looking at serum osteocalcin, which is a marker of bone formation, and looking at urine pyridinolines, which are excreted in disorders where there's increased bone resorption. And we can now do a spot for urine pyridinoline or teleopeptides, and on a spot test, compare them to creatinine, and there are normal ranges of pyridinoline creatinine or teleopeptide creatinine so that we can look to see if our patient has an increased bone resorptive problem. And then again, thyroid disease being another potential occult cause of metabolic bone disease. And ultimately, one of the really important tests that can help us look for evidence of significant metabolic bone disease is a DEXA, is a dual X-ray absorptiometry. And remember, in the most recent KDIGO CKD metabolic bone disease guidelines, the recommendation was to look for underlying metabolic bone disease if there's evidence of significant CKD, MBD, and or osteoporosis. So if there's any reason to be concerned about that, and certainly this child has, as we've identified, multiple potential risk factors for osteoporosis. And for example, post-transplant, the recommendation is to do a DEXA before transplant, to do a DEXA 3 months after transplant, and then yearly if there are these risk factors for metabolic bone disease, which this girl clearly has. And then there are some other guidelines about promoting bone health in these children. So we did a DEXA 1 year prior to transplant, and at that time, her lumbar vertebral bone mineral density Z-score, and this is a Z-score that is adjusted based on height, which is the most recent recommendations. There's a longitudinal NIH study that looked at correcting Z-score for height and showed that that was better than using a Z-score for age. That website is actually available online and is now being hosted by CHOP. So we'll call it an NIH or height adjusted Z-score. And if you look, her total bone mineral content Z-score was also low, but not out of the normal range. So here she was post-transplant with, again, a Z-score that was low normal, but now at 4 years post-transplant, at the time of her second fracture, her Z-score was now clearly out of the normal range, even adjusting it for height. So interestingly, if you just used her age, lumbar vertebral bone mineral density Z-score, the one that the machine spits out, she was minus 4.8. So again, this was a small child for age. So it really is crucial to adjust it for height and not to accept the results that come out in the reports from the DEXA machine itself. So remember, one of the values of the DEXA is that it allows you to look at multiple bone sites. It actually has 1/20th the radiation of a chest X-ray. And it does not require an absolute still child, the kind of thing that's required for an MRI. So there can be a little bit of motion during the test that still allows you to come up with the appropriate reading. The DEXs are very precise with good accuracy when they're compared from reading to reading. And again, it's really important to adjust the bone mineral density readings for height-adjusted normals that were initially derived from the NIH study and are now hosted on the CHOP website. So you can just Google pediatric bone density CHOP and come up with this formulation. In occasional children, we'll do a QCT. The QCT is more radiation, and it requires a child to be absolutely still. Has very good precision and accuracy, but it is more expensive as well. So the 2019 International Society for Clinical Densitometry released official guidelines about pediatric densitometry readings that really suggested that the term osteoporosis should not appear in DEXA reports without a clinically significant fracture history. So if there's low bone mass, we should call it osteopenia or low bone mass, but it's only with the addition of clinically significant fractures that we are recommended to use the term osteoporosis. So this girl clearly fits into the designation of pediatric osteoporosis with her 2 fractures. Interestingly, Michelle Denberg recently looking at the CKD database showed that 16% of the children in the CKD database had a fracture prior to entry, and that 16% had another fracture over 4 years of follow-up. Fractures are more frequent in the males than females, and the fracture rate was actually in the males 2.4 times that seen in the normal population, and then the females 3 times that seen in normal population. And if you look, the factors that predicted for fractures, an increased fracture rate, were older children with poor growth, children who had lower GFRs, but interestingly, children that had abnormalities of walking. So elements of decreased mobility were clearly associated with an increased fracture rate in these kids with CKD. So given her osteoporosis, what are her treatment options?
Bisphosphonates.
I would go for the same.
Adding calcitriol to this girl, giving her more cholecalciferol, using an anti-rankle antibody, yes. So I think we can make a case that this is a child that deserves bisphosphonates. And where I think at one point we thought of bisphosphonates as to be avoided in children with renal and adults with renal insufficiency, there now is over 10 years of adult experience using bisphosphonates in adults with decreased GFR, demonstrating good results and good safety. So bisphosphonates are indicated for primary and secondary osteoporosis. They decrease bone turnover by decreasing osteoclast activity and by pushing osteoclast into apoptosis, and therefore, while osteoblast function continues but osteoclast function declines, you promote mineralization in these children. The molecular mechanisms are unclear. Bisphosphonates are stored in bones, so they tend to have a long effect. And there are multiple osteoclast intercellular pathways that are affected, so they probably are working through multiple mechanisms. They inhibit an important element that's involved in osteoclast function, farnesyl diphosphate synthetase. And they also are metabolized to toxic analogs of ATP only in osteoclasts. So in this girl, she was started on IV zoledronate. She received half of the usual dose because of our concerns about bisphosphonates being renally cleared and not wanting to overdo the bisphosphonate result. And over the 4 years of treatment now, she's had no further fractures, and she's improved her bone mass and also has had a stable GFR. So you can see now she started therapy at 15 years of age, and 4 years later, her lumbar vertebral BMD Z-score is now improved to -1.3. and she has had further increase in her total bone mineral content and improved her total bone mineral content Z-score as well. So the learning points I would like to leave you with is that cystatin C-based calculations are essential for accurate GFR in special populations of children. Children with muscle wasting and disorders in particular, children that are obese, and then conversely, kids that are potentially getting into extra sources of creatine like bodybuilders are another situation where cystatin C will give you more accurate GFR. And we could spend an entire hour talking about the benefits of cystatin C in neonates, as highlighted by Dr. Filler in his previous presentation. So that's another very important special population. I would have you recognize that metabolic bone disorders do occur in children with CKD, but it's not always CKD MBD, and that other issues can arise. We've treated now 4 children with CKD, with metabolic bone disease, with varying degrees of immobilization and decreased activity. All of them had osteoporosis as defined by low Z-score with fractures, and all 4 have done well with bisphosphonate therapy. The key diagnostic study to define presence of a significant metabolic bone disorder is the DEXA. And the KDIGO guidelines actually recommend DEXA monitoring if there's evidence of CKD MBD, in other words, significant CKD MBD, and or a risk of osteoporosis. And then lastly, bisphosphonates, in particular IV bisphosphonates, are useful options for children with coexisting kidney and metabolic bone disorders. So I would turn to my panelists and say, have you utilized bisphosphonates in any children with chronic kidney disease?
Very rarely, but I mean, your patient is of female sex, which is a much higher association with osteoporosis. She also is coming to an age where her peak bone mineral mass is achieved, and she's starting it even with the without the bisphosphonated minus 2.6. So you've got to do something here. And I actually would like to return the question and ask, what do you think is a long-term prognosis for the osteoporosis? This is quite worrisome because she's not going to make more bone mineral density.
Yeah. Yeah, and she's not going to mobilize better either, given the natural history of her mitochondrial disorder. So our practice with these children have been to utilize bisphosphonates until we get their Z-score to 0.0 roughly. So we try to achieve predicted bone density for age, and then we stop and observe. Now, I would suspect that what will happen with her is she'll come up to mid-normal, we'll stop, and then she'll slowly decline. But because bisphosphonates are stored in bone, the effect will last for several years even after we stop. So at some point, she may begin to decline enough in her bone mass that this will become another question for her. But I would guess that that's going to be 5 to 10 years from now when this will come up as a clinical question for her.
This is a really fascinating case because it's very unusual.
Yes, yes. And yet I think these are kids we're going to see more of, right? As kids with mitochondrial disorders and kids with muscular dystrophy and other disorders do better, and their renal disorders will have a chance to play out as well.
And I think, we discussed with the first case and the second case, as we get all these patients with complicated condition, metabolic diseases, other problems that in the past they will die very young, and now we're going to start seeing some of them surviving, but with a lot of chronic conditions, including CKD. And then we're going to be probably in the past, we'll say, we're not going to dialyze this patient, we're not going to transplant this patient, but those patients are doing much better now, and we're going to start seeing those patients more and more. Some of the kids with metabolic disorders that in the past, they wouldn't survive the neonatal period. Now we're seeing them, and I guess and in the future, we're going to be dialyzing and transplanting some of those patients and then getting more complications because they have systemic disease.
Okay, so thank you, Dr. Bonilla-Felix and Dr. Filler, for presenting these illustrative cases and having a chance to discuss their key points in clinical care with you today.